Diffuse large B-cell lymphoma has been treated for years with the chemotherapy called R-CHOP, so it's a combination of immunotherapy with CHOP. And that remains the standard therapy for majority of patients with diffuse large B-cell lymphoma. Patients with double-hit lymphoma, which have translocation of MYC and BCL2, are at particularly high risk, and those patients are often treated with intensified regimens like dose-adjusted EPOCH-R or other intensified chemotherapy, poor kit-like chemotherapies. One of the most recent significant advances which we have seen was introduction of the new antibody-drug conjugate called polatuzumab vedotin. So polatuzumab vedotin targets CD79B, and it's linked to vedotin payload. And when added to chemotherapy with R-CHOP, has shown better progression-free survival when compared with R-CHOP. However, did not show overall survival advantage. Having said so, many groups around the world did adjust their frontloaded approach to use Pola R-CHOP, and we use it as well. Well, one update is update on polatuzumab vedotin study, which is called POLARIX, and for a while now, we know that there are two molecular subtypes of diffuse large B-cell lymphoma. There is an ABC subtype, which is associated with worse outcome, and GCB subtype. And what's interesting about POLARIX study, if you look at the subgroup analysis, it appears that ABC subtype is the one which benefits particularly with addition of polatuzumab vedotin, not so much GCB subtype, which opens the question, should we use this selection of non-GCB or ABC patients to choose the best therapy for them with polatuzumab vedotin? We actually do use it at Mayo Clinic, so if you have a non-GCB or ABC subtype, we tend to use polatuzumab vedotin R-CHOP. On the other hand, if you have GCB subtype, we use R-CHOP. Normally, you have to be very careful about interpretation of the subset analysis like this in their studies, like in POLARIX. But because there was no survival difference, we feel that it is appropriate to extrapolate from this subset analysis based on the progression for survival. Again, the study shows no survival advantage. We'll see the update at this year ASH of this study. So that's a great question, and that's an area of very rapid development, and we have a number of very interesting studies. I would generally put them in a couple of different buckets. One is that we have a wave of the studies with bispecific antibodies. Bispecific antibodies are very active in the relapsed refractory setting. So now we have a study of epcoritamab with R-CHOP versus R-CHOP, which is met its accrual and is maturing. We have a study which is ongoing of glofitamab with R-CHOP versus R-CHOP, which is also ongoing. So, and there's some other bispecific antibody trials planned in this space as well. So that's one group of studies which is ongoing. There are also studies of small molecules. So golcadomide is a new generation cell mod, which is being now developed in large cell lymphoma in relapsed refractory setting in combination with Rituxan, has nice activity. There's a presentation at this meeting showing phase 1B in combination with R-CHOP. It looks very promising with very high response rates. So there's a randomized study ongoing of this agent. There are BTK inhibitors, studies are ongoing and maturing. So those are the category of the small molecules. And finally, we have a category of the studies where high-risk patients are treated with consolidation early on as a part of initial induction with CAR T cells versus standard chemotherapy. And those studies will be also very interesting to watch. So I'm confident that over the next several years, the field will change dramatically.